Good evening. Welcome to the third seminar of the series, and I'm glad a lot of you, I see a lot of new faces today. I hope you continue to come, even though there's no one like Steve. But please do try to come to other events. You know, it's a lively forum for all kinds of discussions and ideas. It's really my pleasure today to introduce Steve. Steve Rose, as you know, he was the great director of the School of Social Work when I first came here to UNE. He was the founder and first chair of the Health Interdisciplinary Council of the University of New England. And before he came here, he was also the professor and associate dean and project director for numerous NIMH training grants at the State University of New York at Stony Brook. He is the author of many books and many articles. Just by way of example, some of the book titles that he wrote many years ago. One is called Betrayal of the Poor. Another one, The Structure of Urban Reform, published in 1974, co-edited with a few colleagues. And his latest book is called Case Management and Social Work Practice, published in 1992. Steve is very well known in the area, nationally and internationally, for his progressive views and commitment to human welfare. Steve.
Well, good evening, everyone, and thank you so much for coming. I really appreciate that. We're going to do something a little different tonight because I had a conversation with Anwar about how best to present this material, and went over and over all of the different parts of the literature that I knew and I think I understand fairly well, and came to the conclusion that there's no possible way in the time available, or even if I had 3 days available, that I could share with you the basic ideas that I want you to get a hold of better than a video, which you're about to see. This video is called Unnatural Causes, and it's a film made by California Newsreel. And one of the reasons why I'm happy to show this is because most of the research in the area called the social determinants of health is not done in the United States. But when it is, it's exceptional. And these filmmakers are extraordinary. They have just won a prize for the 2009 award from the National Academy of Science for the best science program of the year. And they have also received awards from DuPont Columbia, the Congressional Black Caucus Health Brain Trust, and the Excellence in Journalism Award, and the Council on Foundations Henry Hampton Award, and other honors. So I just want to share with you that we're going to be seeing the first segment of this video. After that, there are many others, 4 or 5 others, which I urge you to see. It was originally shown and has been reshown on PBS. I also want to just briefly familiarize you with the handouts. Everybody, I hope, has gotten one. The first one is called Unnatural Causes, a fact sheet. And this fact sheet was produced by the same people who made the newsreel. So this is not my work, it's theirs. Next, and very appropriate to the political discussions going on, is a relatively recently released study by folks at the Harvard School of Public Health, showing that nearly 45,000 excess deaths occur annually because of no health coverage. The third one is a chart, which I will make clear, and the fourth is, if any of you are interested in any of this material, there's a resource list or a reading list. And I also hope that you will feel free to contact me at my email address, which is srose@une.edu. So with all of that in mind, we'll go directly to the film. That was not discussed was a moral issue that underlies all of this. One of the handouts I gave you was one that was a recent Harvard study that said 45,000 excess deaths happened in the last year only because of the inadequacy of insurance. And I think that that, coupled with the fact that we saw here 83,000 excess deaths of African Americans occur every year. I think the question that has to be addressed by us, and I think it is being addressed by us passively, is to what extent is it fair in your mind for one excess death to occur? And the second is, if it is fair for even one excess death to occur, who should be making the decisions about who that person will be? Or if we're talking about a population, who that population will be. We are making those decisions, but they're not being made on a moral plane. They're being made as if they were accidents of policy or byproducts of policy. So I want you to hopefully give that some thought and maybe discuss it when we come to the discussion. Nancy Krieger, who you saw a couple of times on the video, says, "Poor living and working conditions impair health and shorten lives. These associations persist well into the late 20th century, despite marked improvements in living standards and medical care, and are not substantially explained by known biomedical or behavioral risk factors." So a couple of things need to be made clear that seem not to have been discussed elsewhere beside this film. The first is that when societies change from communicable diseases being the central lethal causes of death to non-communicable diseases, the distribution of who dies by income remains the same. The second thing that I think we need to think about is, especially in the United States, how does it happen that a non-communicable disease, type 2 diabetes, appears to be spreading faster than most communicable diseases did, and spreading in the same pattern of inequity? So I think that there are a set of issues that come before us and need to be investigated by us as just, not necessarily as health professionals, but as members of a community. Another issue that was mentioned briefly in passing, but is significantly and empirically demonstrated, is that as income inequality rises, as the gap between the rich and the poor goes up, two other things go along with it. The first thing that goes along with it is there is a reduction in the available resources necessary for human health. So as you see the gap in income inequality rising, one of the things that will go along with this gap in income inequality rising is a growing what's called neoliberal philosophy, and that has to do with the belief that market solutions to problems are superior to government intervention. And we can see this in this country more rapidly and more grossly than anywhere else in the world. As the belief in market solutions comes to the fore, what you'll see happening is tax cuts that go to that 1%. Remember in the video and in your fact sheet, 1% of the population of the United States controls the equivalent amount of wealth of the remaining 90%. The tax benefits of the last many years have been the people in that 1%. As that 1% gets tax breaks and tax cuts, a way to imagine this is to try to envision a dollar being taken out of a health fund, a dollar being taken out of a mental health fund, a dollar being taken out of a daycare fund, a dollar being taken out of a domestic violence shelter. Every one of those dollars, that is our dollars, being reconverted into excessive benefits for the very rich, are in fact dollars being taken away from the thriving possibilities of the whole population. And I want to make that point because this is not just an issue of health and disease. The World Health Organization makes it very clear. Health in the World Health Organization's definition is not just a matter of the presence or absence of disease, but rather the presence or absence of human well-being. Health is one factor related to human well-being. It is not the same. So one of the things that I think is an immensely important and central issue for us to consider is if, as human beings, we are going to develop as a species, the resources necessary for that development have to be committed uniformly and equally across the board. People need to be able to develop fully as human beings, and in order to do that, as Dr. Shonkoff and others mentioned, massive investments in the development of families and children need to take place. And that can't occur without a parallel reduction in the inequity every time I talk about inequity, something happens. It's a little unnerving. The reduction in inequity in the distribution of wealth must occur. You can't just take one single issue and focus on it. For example, if you are dedicated and committed to the well-being of children, and child development is a central issue for you, as it is in Maine, there's a task force on child development. The task force on child development is committed and dedicating to everything that many of us, if not all of us, would agree are fundamental resources necessary to the health and development of Maine's children. But if you don't pay attention to what's happening at the other end of the age continuum, you will rapidly begin to forget the fact that the dollars that we need for our children are disappearing in the form of chronic illness care for our seniors and other people who are in their 50s and 40s. This is another way of saying that 75% of all illness contacts with the healthcare system now are for chronic illnesses. More than 75% of all expenses are for chronic illness care. Chronic illnesses, by their very definition, cannot be cured. And many of them, especially type 2 diabetes, are springboards that lead to other issues like cardiac disease, chronic obstructive pulmonary diseases, amputations, blindness, all incredibly dependency-producing, institution-relying forces that do not bring about significant change in people's lives. So if you're dedicated, as all of us I imagine are, to the well-being of children, but we're not doing anything to take on what the causes of the problems of chronic illness are, then what we're doing is front-loading the expenses at the end of life that should be devoted to the beginning of life because there's a finite budget. And I think what we see in our society, at least I do, is the fact that people are seriously divided between different constituencies. We exist in different silos. So the child advocates don't pay much attention to the chronic illness, the Diabetes Society, the Cardiac American Heart Association. All of them are incredibly valuable advocates, but when they advocate only for their piece of the action, the overall action tends to be underplayed. And as long as you're getting your piece of the action, then people tend to be more comfortable, but also, I think, more anxious, because if you've got your piece of the action this year in a declining economy, it doesn't mean you're going to get it next year. I do want to mention also that this whole phenomena of the social determinants of health discussed in the video has been documented systematically by the World Health Organization. In 2005, the World Health Organization published a pamphlet called Social Determinants of Health, the Solid Facts. And this is a way of acknowledging worldwide and globally that the same set of social, political, and economic forces are occurring that have to do with differences in health and differences in well-being, not only between nations, but within nations. They also began in 2005 with a commission called the Commission on the Social Determinants of Health. It's a good name for a commission studying that, I think. And this commission produced its final report in 2008. What I find very interesting is with all of these scholars that we saw on the video, and these are the top people with the, I think Michael Marmot, if I'm not mistaken, was the only non-American. So you have in there this monumental wealth of brilliant, brilliant scholars all across the board. But even with their presence, you do not find a discussion of the 2008 report of the Commission on the Social Determinants of Health happening in the United States. Instead of that, you find discussions about disparities in healthcare. And I want to talk about that in a minute. But I want to read you a couple of quotes from the Commission report. So this is the Commission on the Social Determinants of Health, published in 2008. It's on that resource list I gave you when you first came in, I hope. This is the quote. The social determinants of health are the conditions in which people are born, grow, live, work, and age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. The Commission takes a holistic view of the social determinants of health. The poor health of the poor, the social gradient in health within countries, and the marked health inequities between countries are caused by the unequal distribution of power, income, goods, and services globally and nationally. The consequent unfairness in the immediate visible circumstances of people's lives, their access to health care, schools, and education, and their chances of leading a flourishing life. It goes on, but I won't. The reason I want to stop there is to try to suggest that the human species of which we are all a part is being systematically diminished in terms of our potential as the inequity in the distribution of health prevails. The more inequity there is in the distribution of health, the less developed people are, the less equally contributory they are, the more that process goes on, the degree to which our species prevails, the degree to which we thrive is diminished significantly. So this is, to me, I think, the central moral issue. It's not just a matter of what's fair or not fair, but it also has to do with what are we doing to this planet, not just environmentally, but in terms of our own well-being as a species. And I don't think we think about that nearly enough. I think that we spend too much time thinking about issues that we have to think about, like class and race and gender and sexual orientation, all of them infinitely important in the lives of everyone. But at the same time, all of those categories are what Hillary Graham calls they're social divisions that emanate from this structure of inequity. Hillary Graham is the author of the book that I hope you'll read, Unequal Lives. She's made a phenomenal contribution. She's from the UK, and she's made an amazing contribution to the understanding of this issue. She also is very clear in guiding us toward what kinds of policy issues, what kinds of research issues need to be developed if we're going to address these sets of problems significantly. I want to mention one more thing, and then I'll get us into our discussion, or at least I hope you will. One of the things that was not particularly mentioned, although it was alluded to in the video, is the fact that there are psychosocial circumstances that come with this package of assault on your body that comes from unrelenting stress. And I hope that point was made very clear. Chronic stress is itself a significant problem that is caused by these factors that we've been talking about. The physiological parts of it were discussed, if somewhat briefly, by Bruce McEwen and some of the other authors on the video. But one of the things that comes with this process of chronic illness is the fact that there are psychosocial components to it that need to be mentioned. It's not just that chronic illnesses can't be cured. It's that deprived of the capacity to participate in an empowered, active way in your own health care, the probability of becoming a good manager of the chronic diseases you have is almost totally gone. And one of the things that the research has shown is that there are three interacting psychosocial characteristics that come with the tyranny of poverty and the tyranny of having very little control in your life. The first is a near non-existent sense of self-efficacy. Is that a term that most people know? Self-efficacy is principally discussed by Bandura in a famous book he wrote in 1985, but it basically means I have the possibility of believing that I can shape a direction in my life and organize my life to go in that direction. So self-efficacy takes massive assaults from this experience and exposure. The second one is sense of self-esteem, a sense of well-being and being an important, significant person to anyone in the world. And the third is this lack of what's called internal locus of control, which they did talk about. So if you put together the idea that you have extreme low self-esteem, extreme low sense of self-efficacy, extreme lack of internal locus of control, the probability of being told by a healthcare team when you're first diagnosed with type 2 diabetes is that all you need to do is exercise, diet, and run that should take care of you. You'll be okay. And I keep saying to people, I have type 2 diabetes, and right now, as I figure it, if I run 31 marathons without eating in between, I'll probably be okay. But I haven't tried that yet. I do want to emphasize this fact, though, that if people don't have a sense of self-efficacy, a sense of self-esteem, and a sense of internal locus of control, their capacity to participate in what the chronic illness interdisciplinary models call the chronic illness model, the interdisciplinary chronic illness model, is non-existent. And that means that the probability of their being able to successfully manage their first diagnosed chronic disease is minimal, which means that we can start to begin to explain why, as you go down the income ladder, you begin to see two things happening, and they're very prominently happening in Maine. You begin to see, for example, the initial age of first diagnosis of type 2 diabetes is dropping rapidly into the 50s and 40s. We know that for women who are diagnosed with type 2 diabetes and who are receiving Maine Care or Medicaid, they cost the Medicaid system twice the amount of any other person in any other disease category. And the reason is because type 2 diabetes for them is frequently a springboard into cardiac disease, into other kinds of illnesses that are well known to be associated with type 2 diabetes. So again, want to point out that if we're not attacking the causes of chronic disease at their core, at their fundamental level of the inequity levels, then we are promoting a huge and developing population of people for whom there will be no capacity to help participate in their own health care if it's delivered the way it currently is. So I want to just briefly summarize by saying again, if you're a person interested in chronic disease, you've got to pay attention to these issues. If you're a person interested in children, you have to pay attention to these issues. If you're a person interested in the health care for African American and other minorities, you have to pay attention to these issues. If you're a person interested in the issues of gay, lesbian, and bisexual and transgendered health care, you have to pay attention to these issues. It is because we are of a species, not because we are of subgroups created by the structures that make inequity inevitable. I'll close by saying that last year, 2008, was the 60th anniversary of the UN Declaration of Human Rights. Article 25 states that all people, quote, have a right to a standard of living adequate for health and well-being of self and family, including food, clothing, housing, and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond their control. Please note that in this statement of human rights, there's a specific mention that the preconditions for health as a human right are all identified. As Hillary Graham has said, they exist at the level of the material circumstances necessary for health and the security that those material circumstances will never be taken away from you. One of the issues that ran through the video was not just the absence of housing, not just the absence of food, not just the absence or presence of employment, but the whole possibility that insecurity on any of those and other related issues could happen to you at any given point in time. And if you think about this in relation to what's going on in our society now for people who are losing their jobs, the probability that loss of job or the threat of loss of job brings with it the threat of loss of health insurance, which brings with it the threat of the loss of housing, which brings with it the threat of loss of health. So whether or not the UN Declaration has the meaning to you that it does to me, or as the last part of the video says, whether from a position of pure self-interest alone, so that the concerns about species are the mutterings of some old academic. If that's where you're coming from, whether you're at one end of the continuum or the other, we have an urgent necessity to act on the issues raised in the video. So I will close my comments there and look forward to yours. Anyone? Yeah.
You I think in the video they said that income inequality was at its lowest in the U.S. in 1976. That's quite remarkable. What are your thoughts about what kinds of policies we need in place to move in that direction again?
Well, isn't it interesting how they're not being discussed in the health reform issue? I mean, the health reform issue isn't even discussing what's a fair amount of profit that the insurance company should get, which is, to me, absurd. I think the issue is where you start. It's very simple. The tax cut that was enacted by the Bush administration and their followers in the Democratic Party needs to be reversed. This is billions upon billions upon billions of dollars, which would pay probably for the better part of universal health care with a public option in a single payer system. So that's the first place. The second place is very simple. Again, you just have to think about where is money being spent and how can it be redirected? To what extent would the money that went to fight the false war in Iraq, had it been converted into the possibility of providing health care, daycare, and funded public education, or funded or better, much more better informed and better supported private education, what would our country be looking like today were those dollars shifted? Yeah. Let me first ask Jan if that's...
Yeah, this is great to hear, and I'm also wondering what you think about living wage campaigns. I've heard that the living wage in Portland, Maine is now $20 an hour.
The living wage in Maine is somewhere around $37,000 a year. The poverty line's around 15. In a research project that we did here, working in collaboration with Counseling Services, Inc., some years ago, we found that we were working with low-income people with both mental health challenges and physical health problems. And we found that the income level that they were living at was 1/2 of the poverty line. Right, if you have a concept called a living wage, so 1/2 of the poverty line is 1/4 of a living wage. And I think that one of the things we need to try to get clear in our heads, if people are living at 1/4 of a living wage, it means we're killing them. Right, if you're either living or you're dying, or moving toward one direction or another. So if there's something called a living wage, which is a calculated wage by the Department of Bureau of Labor Statistics, that it covers an adequate amount of income for a family to live in a different geographic area, and you're living at 1/4 of that.
Well said.
Yeah, I wanted to follow up on your comment about unnecessary war. If you watch TV, we're being bombarded now with ads against the healthcare thing from political primitives like the U.S. Chamber of Commerce. And their particular ad talks about it's a $1 trillion bill. But by my calculation, in 10 years, if you take a look at the defense budget, we will spend between $7 and $9 trillion. Now that's a tragedy in itself, but what's really a tragedy is there's not a peep of discussion about that, not a peep. And unfortunately, our new administration, the Obama administration, is an incredible disappointment in this whole area. So, crepe hanger that I am, that's where at least some resources could come from, because it's not just funding health care, it's funding all the other sort of social equity things that were alluded to in the film.
Yeah.
So
I think there's two comments I want to make about that, Paul. The first one is that without getting into a critical discussion about the war, if you choose not to, just getting into a discussion about the privatization of the functions of war that are being transmitted to Halliburton and other companies like them. There are now almost as many, if not as many, privatized workers in Iraq as there are soldiers. All of those functions used to be done more, okay? All of those functions were previously performed, and I think rather adequately, by our military itself. So if you took the profit margins and the costs of that alone and shifted a portion of it back to the military to be able to do those own functions and use the rest of the money to pay for what we need to have happen, that's one thing. But I would say, to me, how many of you noticed within the last week the report on the number of children who are going hungry in the United States? Almost everybody. Do you see any connection to future health? None. See any connection? You know, I mean, to me, I think I'm privileged at my age to be able to look at things lined up side by side and see there's something particularly weird about them. Next to the article on hunger and what was happening to children in Maine and in the United States was an article about health reform. And it had nothing to do with one another, except that this strange juxtaposition in the Portland newspaper, which they seem to do quite often. So again, to come to some understanding, 20 to 25% of the children in the United States, and I think the percentage is actually higher in Maine, are either hungry all the time or worried about it.
And therefore less difficult.
Yes. And you know, it's absolutely right. And if you turn for a minute, everybody who got a handout should get this chart. One of the typical ways that the social epidemiologists think is in terms of not just equity or inequity, but what happens in what they call a life trajectory. And they start by, this is just an attempt to diagram the fact that if there is inequity in intrauterine position, in intrauterine conditions at birth, that is going to probably begin to create a life trajectory. The kids born in those circumstances to parents who are at low income and or there's other research which they don't mention that's connected to family violence and later health. If you find inequity in the distribution of intrauterine health, you're going to have inequity at birth, and you can be sure that those are the children who will be going to the schools that are least well funded, where class sizes are bigger, where the environmental toxins are greater, and so on. And that's just trying to talk about this process of cumulative impact, which is the term that they use. That's the bad news. The good news is once you see this, it gives you every opportunity to create an intervention target at every stage of the game. To create an intervention target that tries to specifically provide people with the contradiction of what their life circumstances had provided them with before. We can talk about that if you like. I saw somebody.
Give us a ray of hope. What initiatives are being enacted to make things, give us a ray of hope. What initiatives are in process to make things better?
Well, I think the first step for me would be, I actually think this public broadcasting system video has had more impact than anybody could have imagined and should. So I believe that that's very important. I also believe that the health reform debate is important, but I'm going to put an asterisk there. The asterisk is, if there is no public option, and the public option is not made available to a significant enough variety of people and number of people so that it can compete with the private sector, then I withdraw my comment that this could be a ray of hope. But I do think, at least for now, there's still a ray of hope there. But it's important to keep in mind the point that was made in the video. I've seen this so many times that, to me it's like there's both the whole video and a bunch of instances and moments. One of the points that they make is that if there were universal health care, single payer in the United States tomorrow, and people actually got access to health care, because single payer isn't sufficient. You have to have single payers who will be able to have the payer find what they pay acceptable to the providers. And that, as many of you know, in Maine is a significant problem. People can have a Medicaid or a Maine Care card, but they can't get health care because the providers won't accept it because the rates are too low. So you go back to this point. If people tomorrow actually had universal health care, all right, there we go. You notice how it always does that when I'm making a politically progressive point. If there were universal health care, single payer tomorrow, and people could actually get that care, that would produce, according to health economists cited in their research and in other research that's in the packet I gave you, that would reduce the burden of suffering by 10 to 15%. It is not an answer to the healthcare disparity, the healthcare inequity problem. But it is a necessary step that must be taken. I don't think any of us can in any way casually say that this is not an important issue if we have healthcare ourselves. I just don't think we can. That level of selfishness escapes me. So I think that there is a possibility if this happens. If it doesn't happen, then I think there needs to be some organized resistance in the community. There's enough people, 70% at one time of Americans polled on the issue of public option wanted it. So all of a sudden you've got a sort of a bit of a contradiction between the people who want a public option and politicians who are getting paid off by insurance companies who don't. I think that tension is good. I believe that the progressive parties, I don't mean political parties, but I mean progressive political groups on the left are now threatening to do what regressive political groups on the right have already done in the 23rd District in New York. They're saying, if the person running for office or running for re-election in the case of two people from Arkansas and one from Louisiana, if they don't support what 70% of the people want, they want to run somebody against them in a primary, which I think is a good idea. So I think that's there. I think that there is a groundswell. I know that this is true in Maine. There's a groundswell of people who actually get it about the importance of early childhood development. What they don't get is if they're dedicated and committed and vigorous in their campaign, as they are, and they're talented and skilled as well, they need to pay attention to what's happening at the other end. Because as I tried to say earlier, if you are absolutely dead ahead committed to the whole idea of human thriving, and you understand that this starts in utero, and you develop that for those people who want to keep their children and have children. If you understand that, that's a wonderful start, because at some point somebody's going to say, in order for that to happen, what has to come first? What has to come first is some much larger change. So I think that that's there. But I can't be much more, maybe other people can help me out with this one. I mean, anybody else? Warren Buffett. Yeah. Maybe he should run for governor of Arkansas.
Later in that same speech, he said that he should be paying 5 times the taxes that he currently is. But until we can change the arguments,
Can you repeat what you just said?
I said Warren Buffett later in that same speech said that he should be paying 5 times the taxes that he currently is, being one of the richest people in the United States. But it's a case of you make the rules and I'll play the game. And his tax people do not voluntarily pay 5 times as much as the tax regs say he has to pay. But I think farther than that, Steve, we've got to reframe any discussion of values or morals. Constantly we're seeing not only Republican, but some Democrats debate whether we can afford to pay for the health bill while we still keep taxes low and or cut other spending. Until we get back to where we were in the 40s and 50s, seeing that there are certain things that government can't do better than anybody else, and certain things that only government can do, and that it's the way we ought to structure the economy is by saying what we want government to do, and then we are willing to pay the taxes to do it, and that paying taxes is an honorable and even patriotic and morally positive thing to do. We're not going to get anywhere. As long as we let them frame the debate of starve the beast, we're in trouble.
I agree. Got to get you a microphone. Making me nuts.
First of all, I'd like to thank you both for showing us the film and for your comments afterwards. And I'd like to applaud 2 aspects of what you've said, 2 points that you've stressed. One is a concern with humanity generally, and the other is the emphasis on this as a moral issue. But I'd also like to point out that if not everyone, virtually everyone in the film and in the subsequent discussion has privileged their own community, their own nation, their own state when talking about concerns about inequitable distributions of wealth and health care. And that seems somewhat incoherent to me. If we take this seriously, that this is a moral problem, and as a moral problem should be a matter of universal concern, surely we should look at this in a broader context than simply the well-being of those with whom we identify.
Yeah, I agree, but I think that there's an effort being made to produce, let's say, the first levels of consciousness. I mean, this is an effort to me to begin to take on some of what Hugh was saying just before you, to take on a switch in the debate, a switch from health disparities, which, again, health disparities it's important that African American men die 11 years younger than white men across the board. It's important to deal with all of those issues. Those are disparities, I don't doubt that. But we can't take them on as if they were the issue. And I think the point that we're trying to get at in this video, I don't know why I'm taking ownership, I wish I'd had it. The point that they're trying to make in this video is that there needs to be the beginning point of a consciousness of those issues, just as you said them, because there is some connectedness to global issues. For example, some people are asking, I don't know if you remember in the video, but a point was made, we spend 50% of the world's costs for all medical care in the entire world. How do we rank 35th on life expectancy? And if this is a country that has such dedicated commitment to children, how on earth can we possibly be 30th or whatever it is in infant mortality? This is, I think they're trying to bring a consciousness of this issue. But I think the other thing that happens, and Peter, this is one way actually also of responding to your question. What are all those countries up above us doing? This isn't a socialist capital, despite the efforts of the far right. There's nothing to do with socialism going on here. None of those countries that are scored way up above us, not one is a socialist country. They're all capitalist countries in different forms. So they're doing something very different. And I think that you saw little bits and pieces of snippets at the end. That project in Seattle, by the way, the guy that was talking about the meter in the house in Seattle is Nancy Krieger's brother, who is he's the director of public health in Seattle. And trying to take a look at those kinds of issues to me is very important. They're trying to create a center for health equity in the medical school at the University Hospital in Louisville. That's very important. There's a new federally qualified health center that just started in Portland. Can we find ways to support it? Can we find ways of joining with them? We now being not just the University of New England, but the whole community. Can we begin to raise question about how and why money is being spent the way it's being spent when it's detracting from what constitutes health? There's a concept out there called health impact assessment. And I think, they made mention of the fact every economic policy is a health policy, every housing policy is a health policy, every social policy is a health policy, every welfare policy is a health policy. I think that this is the kind of stuff that we need to try to come to terms with and begin to ask at local and state levels as well as the national level. I just think that's there, yeah.
As an extension of that point, I have real concerns that our medical care delivery system is not part of the discussion. And the reason I say this is because our medical delivery system basically does not address health care. What they address is disease management. I think that will point to one of your concerns about the high cost is because of that. We're dealing with disease management. My question to you, and maybe to others in the audience, is how do we get conversations. How do we engage our medical delivery system into concerns with concerns about this? We can set up a few centers, but how do we get it going on a national basis?
Well, I'm going to give you my shot at this. I think a couple of things are happening. The first is recognizing that chronic illness care is inherently interdisciplinary and multi-sectoral. Interdisciplinary meaning that there's good research out there that now already shows that if you have state-of-the-art medical care, which you deliver as the totality of care for chronic illness care, disease management scores go down. Right, so we know that there needs to be a whole bunch of different kinds of information, support, and practice by all of the health professions and actually people in the community as well. So there is a recognition of this in the research. The second part that I think is very important is the necessity to shift the focus of what we're doing from the delivery of care to the accomplishment of outcomes of care. And that is a very technically complicated problem because it means that the retrospective reimbursement system for paying for each medical procedure done is a godsend to the insurance companies who are controlling it and the providers who are glorifying it. There needs to be a systematic form of capitated financing which can only come with a single payer system, whether the insurance companies are private or not. They have to be completely regulated, and there has to be, once you get to that critical discussion, you're in the midst of a discussion about population health rather than individual health. And that gets you towards some of these issues. That's just my thinking about that. But anybody else have any responses? It's such a great question, as all of them have been.
It reminds me just of the frequently said that where we should be giving people all the health care they need, whether they can afford it or not, our system now gives us all the health care we can afford, whether we need it or not. And too often we don't, at least in the form that it's available.
There's somebody, Anwar? Yeah.
It's a different question, so if there's other answers. No. Okay. As you were talking, Steve, I listened and heard you saying things like predictors of a shorter life include job insecurity and no certainty about the future and whatnot. And as a humanities PhD, I'm listening to this thinking all of the programs in the humanities would shut down overnight if they just advertised them as, wow, you can shorten your life and be miserable and have no job security and all of these things.
You mean that the private insurers would be promoting this as a necessity not to have to pay expenses for you?
Or, yeah.
Legislators they're worried about death panels on the Obama side, right?
Yeah. But to go back to what David was saying, I think you are very persuasive in saying that the looking at the healthcare disparities isn't an end in itself, that this is an indicator of much deeper social concerns. I wonder if you wanted to go a little further and say that seeing as the healthcare system, healthcare professions are doing such a good job of going along with the problem rather than resolving the problem, whether the people to look to for solutions may not be in the healthcare professions at all.
Well, I for sure would not want to exclude them. And I'm not sure even why I'm saying them. I would not want to exclude us. But I think that we need to have two things at the same time: a critical consciousness about what's happening to the people in the health provider world, and a deepened understanding of what it's like to live with the contradictions they face. Because if we don't deal with the contradictions they face, then the consciousness and caring and compassion that we feel will just simply become rhetorical. So for me, I think the issue is how do you engage them? How do you engage them in partnering with you in a framing of the issue that hasn't yet occurred to them? And it's certainly not because they're dumb. It's because of the very things you said. They're immersed in their own environment, and they're having to adapt to their own environment. And the way they adapt to their own environment, because they don't want to be unemployed early, right? And they're not, and they don't see a future as a PhD in humanities, right? So we want to keep them doing what they're doing, but we want them to do it in a way that works with us. And they will have special insight from their direct patient contact that we don't have. Because it's one thing to talk about this, it's another to try to work with it. And I think what we have to do is appreciate their struggles, but be critical of them. Yeah.
I have a question about the extent of how discriminatory behaviors on the part of medical healthcare providers towards those who are less educated and towards those who are obese and likely to have, or overweight, likely to have more health problems. And I'm thinking partly of a personal essay by Marianne Worley that I read years ago about how she was treated as an overweight woman, which made her very reluctant to have any contact with doctors, and then other sort of anecdotal experiences that younger siblings of mine have experienced with doctors who clearly did not treat them with respect, did not allow them to, and whether that's also a piece of the picture about not providing sufficient and effective health care for...
Let me tell you a story that will partially answer this. I had the wonderful, wonderful good fortune of spending some time in Helsinki, Finland some years ago, and one of the faculty in the department where I was working was a medical sociologist, and she'd been doing a lot of, I think, really interesting work. So she came up with this idea that people are experiencing just what you described. So she put advertisements out in every major community newspaper in Finland advertising an essay contest. And the topic of the essay was, I have had problems with the medical profession in the following ways. She got hundreds of essays, and she, being a good qualitative researcher, you know, she did content analysis, but she actually did award a prize. And the prize that she awarded was to a woman who had come from a rural area of Finland who had injured her back, and they could not arrive at a diagnosis. And when you're outside the boundaries of an existing diagnostic system, and the identities of the people who are your providers are tied to the diagnostic system more than they are tied to you. If you present a problem to those diagnostic systems, you present a problem to them. And if they begin to have a problem, the first round, who would like to guess what the first round is after this initial, you know, discombobulation? Psychiatry. You gotta be nuts. Right? So you're referred to psychiatry and you get a 100% cure in psychiatry but no change whatsoever in the medical condition, which is great because it means pharmaceutical companies have done very well. You know, you've imbibed at a great expense to somebody without any need for it. So that would, to me, would be the perfect circumstance of pharmaceuticals in this country. But then she went on to another doctor, another doctor, another doctor, and the same thing happened every time, until finally she arrived at an emergency room where the doctor was dealing with the emergency, dealt with her comprehensively, and found out what the problem was. So I think the issue is people who don't present themselves to doctors as compliant objects. A guy by the name of Paulo Freire, who's influenced my work, says subjects know and act, objects are known and acted upon. For whatever reason, maybe not the least of which is that physicians or PAs or nurse practitioners often have, 8 minutes, 15 minutes, in which they can do a lot more than they maybe do now, but still, they don't have a lot of time, and if I come in and present them with a problem that makes their identity tenuous, I am going to be persona non grata. I'm the problem. And I think that that's very often what happens. And the whole idea, but the more we get to this issue of outcomes, and that, Peter, back to your question about there is some positive stuff going on, paying physicians or healthcare settings for outcomes. Now, if the reason for getting higher scores is that they're disqualifying the more troubled and complex people, that's not good. But hopefully that's not what's going on. So I think that that's the issue. I know, I have great medical care. I'm very happy with my medical care. But if I have to go see a doctor for any reason other than a typical routine visit, my partner in life goes with me. And the reason is not because I feel like I'm going to be invalidated at all, but because if I'm presenting stuff that's not fitting into the paradigm, not fitting into the conversation, I want somebody else beside me there who's listening to it. So I would say, if like with your siblings or something, if you can go with them, because that alters the dialogue. Yeah.
Yeah. Thank you for your presentation. Proceeding from two assumptions that all politics are local, and that facts are stubborn things, where would you recommend we go to find the local facts to supplement the national facts that you've been providing us, so that we may be presenting our congressmen and representatives with letters and encouragement that they may be considering their positions or reconsidering their positions?
That's a great question. I think one of the things, local to me would be trying to get, you have to get data. Remember, somebody in the video said data talks. You have to get some kind of data. So I would say that one of the things I'd be interested in knowing is what the patterns of diagnostic patterns are that are occurring over time in all of the primary care settings in town, if we're talking about Portland. I would want to know, have they got any data that shows for chronic disease? I would focus entirely on chronic diseases because I'm narrow-minded. Right? I'm monomaniacal, straight down the line. So I want to focus on chronic diseases, and for me, the principal focus would be type 2 diabetes, not just because I have it, but because it's the springboard to so many other medical problems that are extreme high cost and extremely disabling. Right? So the sooner you can get into the life of and join with somebody who has type 2 diabetes in some meaningful way, the greater the probability, if you're just focused on cost alone, of reducing comorbidities and repercussions of them. So I'd want to know that, and I would want to ask, if we could do it, I would want to know for the entire panel of people that you have in your clinic with type 2 diabetes, what's the cutoff point in terms of a measure like hemoglobin A1C? How many people scores are going up? How many are staying the same? How many are coming down? And then you're going to get a scatter on that. And I would want to see, wow, what are you doing to try to bring down those scores over here? Because they're the ones that are causing you the most problem, and they're the ones, if you ever get paid on the basis of your outcomes, are going to be the most severe problem. So I try to join with them on the idea of outcomes, looking at what the patterns of illness are, who fits into what categories in the pattern, and is there some way of us, when I say us, I'm talking about the university. But I'm not excluding anybody else. I'm just saying, is there some way that we can join with people to try to take on the problems that are besetting the providers as well as the problems that are besetting their patients? I see our time is up, so I'm going to thank you very much for participating with me in this, and I hope it was useful to you.
Thank you so much.